Greetings, friends. In this module of Medicine Beyond Harrison series, and we approach to the sedatives for physicians. This is completely for educational purposes. Let's get started. So, the main goal of sedation in inpatient setting is the safe sedation and the use of benzodiazepines and melatonins in the ward. So, before you prescribe any psychotropic on the ward, we'll try to create a mental checklist so that we will ask yourself what is the target symptoms and how to manage all those things. So, this is the mental checklist before you start giving any sedative drug in the ward for whatever the reason may be. We'll try to create a checklist. So whether it is only insomnia, if it is only insomnia, just give a hypnotic drug, or if the patient is already on antidepressant, adjust the antidepressant dose. If the patient having severe anxiety or panic disorder, you can give short acting benzodiazepines like Lorazepam, or with plus or minus selective serotonin reuptake inhibitors like sertraline, anything like that. If the patient is having delirium or agitation with psychosis, usually in case of ICU or shifting from ICU into ward, alcohol withdrawal patients, in all these patients, usually antipsychotic drugs is preferred and not benzodiazepine, except for withdrawal symptoms where benzodiazepine also given. So alcohol and benzodiazepine withdrawal in such kind of patients, benzodiazepine is the first line, other than antipsychotic. So, what are the medical causes and how to address all these things? So, for example, delirium can occur in many other medical causes such as hypoxia, sepsis, hypoglycemia, then hypercapnia, then hepatic encephalopathy. In all these cases, try to fix the cause and avoid benzodiazepine because it worsens the confusion and also may lead to furthermore sedation, decreased ventilation, and can also lead to silent cardiac death. So, any red flags or comorbidities for giving sedatives that we'll discuss. So, OSA and COPD, a very major risk factor of giving sedatives because it can lead to hypercapnia and can lead to silent cardiac death or respiratory failure. So, in case of elderly or fall risk, already the patient is on high risk of fall. So, on giving benzodiazepines, the patient there is increased risk of fall and may lead to further more damage. There may be need to a fall and a head injury. Then further may need a CT scan. Then when into the CT scan, the patient may get agitated. Then for agitation, we'll give an antipsychotic. Because of an antipsychotic, there will become retention of urine. Because of the retention, we will again put catheter. We'll again induce sepsis, and again there will be delirium. So it will become a vicious cycle. So always avoid giving sedative drugs in elderly or patients with high fall risk. Liver failure patients, invariably all sedatives are uh, used with caution in liver failure because there is increased accumulation of these metabolites. So on opioids, pregabalin or any other CNS depressant drugs, this will begin additive effect and further lead to more sedation effect. Also consider the history of use of substance use disorders. If yes, either avoid or use minimal doses with close monitoring. So these are the conditions. Now we'll go into the next patient. So always remember there is a time horizon. Inpatient sedatives should almost always be used SOS or very short term, that is less than 2 to 4 weeks, due to dependence or high tolerance risk. So always keep the sedative in SOS in the drug chart. So now we'll jump into benzodiazepines. We will discuss about the general principles and the relevant content for inpatient setting use. So common IPD inpatient setting options that you will touch are basically this Lorazepam, Diazepam, Clonazepam, and Midazolam. Lorazepam we can give in all three routes, such as oral, IV, sublingual. It is the best workhorse for acute anxiety, agitation, and alcohol withdrawal, status epilepticus. The one advantage of this lorazepam it is liver safe. So and diazepam it is long acting. So consider diazepam only if long acting sedation is preferable. Good for alcohol withdrawal and seizures. It is always avoided in cirrhosis and in elderly patients. So in liver condition problem, prefer lorazepam. Whereas if you want for long acting, then prefer diazepam. Also, we can use clonazepam for seizures, panic, restless leg syndrome, and akathisia. Both diazepam is available oral, rectal, or intravenous use. Clonazepam is only oral. Midazolam, do not consider giving it in watts. It is a highly lipophilic drug, very fast acting, can lead to severe sudden sedation. So it is used for pre-procedural sedation and ICU sedation. Also used for NIV tolerance. It is short acting, but it is very potent. So always keep in mind not to use midazolam in wards preferably. So when not to use benzodiazepines. So Because absolute contraindication is the night sedative default for all. In case of confused elderly patients in delirium, try to avoid. In case of respiratory failure patients, try to avoid. So, in for long-term usage, more than 2 to 4 weeks, try to avoid for generalized anxiety disorder, insomnia because of increased uh, dependence risk. So, we'll discuss about the common shared properties of benzodiazepines. Because the indications are mainly used for severe anxiety, panic disorders. In case of insomnia, that is, which is when it is severe and distressing, when non-drug measures fail, that is sleep hygiene technique, soothing music. So when these techniques fail, in case of alcohol, sedative or hypnotic withdrawal, acute seizures, status epilepticus. For status epilepticus, IV lorazepam, diazepam is a preferred drug. Adjunct for acute agitation when antipsychotic alone is insufficient. So there are a few absolute contraindications for benzodiazepines, such as acute respiratory failure, severe COPD, OSA not on CPAP, myasthenia gravis. If you give an sedative, the patient may go into respiratory failure. So predominantly, all these contraindications evolve around respiratory risk and respiratory failure. So other than that, it is pregnancy first trimester because of a possible teratogenicity, floppy infant, neonatal withdrawal, and hepatic encephalopathy. So for acute alcohol intoxication or opioid intoxication, there is a risk of cardiac arrest, hence not preferred. So yeah, now we'll the whole these class adverse effects are like sedation, cognitive impairment. There is high risk of falls, fracture, especially in elderly. One few notable point is there will be paradoxical agitation after the effect of the drug goes off. There can be paradoxical agitation, disinhibition, especially in elderly or brain injury. So yeah, now we'll go into the lorazepam, which is your safest default benzodiazepine of choice in the wards. So it is a short to intermediate acting. That is why it is preferred. It has no active metabolites. It is metabolized by glucuronidation in liver. So it is safe in liver disease also. It has both. It has IV, peroral, and sublingual options. In what dosing, it is a zero point 1, 0.5 to 1 milligram per oral sublingual stat to a maximum of 4 milligram per day in case of acute anxiety. In case of insomnia, start at low dose 0.5 to 1 milligram per oral HS, maximum of 7 days only. More than 7 days, it will cause dependence. So in case of status epilepticus, give 4 milligram of lorazepam over 2 minutes. That is low IV. So yeah, the indications are mainly are acute severe anxiety and panic disorder. Then acute agitation in medical patients with antipsychotic if psychotic, avoid in delirium. So alcohol withdrawal patients, pre-procedural anxiolytic, then status epilepticus. Yeah. So contraindications are try to avoid this in severe hypotension or shock. The IV bolus may worsen the shock. High dose continuous IV infusion in renal failure. There will be propylene glycol toxicity or AGMA, increased osmolality gap. So try to avoid it in renal failure. So it is always mandatory to adjust the dose in frail, elderly, or severe COPD patients or in liver disease patients to reduce the dose by almost 50%, which is always necessary in case of lorazepam use. So off-label uses are like catatonia, akathisia, and bipolar mania are also off-label indications for lorazepam use. So when not to choose lorazepam, this when the patient is delirious, hypoxic, septic, all these kind of patients, choose an antipsychotic. Examples such as haloperidol instead of lorazepam. So when the patient is having OSA and not on CPAP with night desaturation, always avoid benzodiazepines for sleep. Use non-drug strategies or consider low dose trazodone or mirtazapine, which we'll discuss about the antipsychotic module. End-stage cirrhosis with encephalopathy, always avoid it in such kind of cases, or absolutely minimal doses with the ICU level monitoring. So for diazepam, it is a long-acting drug, good for withdrawal, for alcohol withdrawal. It is always bad for liver and elderly patients. So this is the key takeaway points. It is a highly lipophilic, long half-life, and active metabolites are present. So it is bad for elderly and liver cirrhotic patients. The main indications are for alcohol withdrawal, especially where fixed dose long acting taper is used. So for acute seizure also diazepam can be given if lorazepam is not available. It can also be used for muscle spasms, tetanus. Also, guidelines often list diazepam for severe anxiety and insomnia, but modern practice suggests and strongly discourages new long-term starts due to accumulation, especially in older adults and accumulation of the active metabolite. So it is always good for alcohol withdrawal and seizures, not for other causes. Again, consider it very cautiously in elderly, frail, fall prone, and moderate to severe liver disease patients, and other common considerations that you will follow in benzodiazepines. So for alcohol withdrawal, it is always a fixed dose protocol that we follow in case of alcohol withdrawal patients. So it is diazepam 10 milligram per oral Q 6 hourly for day 1 to a total of 40 milligram. Then on day 2, it is Q 8 hourly reduced to 30 milligram. On day 3, it is 5 milligram Q 8 to 12 hourly. That is around 10 milligram of diazepam. So tailor based on the withdrawal scores and comorbidities. Can also be used for acute anxiety and severe agitation where lorazepam is not available. Can also be used for acute seizures, status epilepticus when lorazepam is not available. So there are few indications where benzodiazepine is avoided. Even if you need a benzodiazepine, avoid diazepam in case of cirrhosis or child bug B, C. Use lorazepam instead, low dose. If the age is more than 65, try to avoid because of high fall risk delirium. Prefer lorazepam. And when you need only a very short effect, prefer lorazepam and not diazepam because, or in fact, prefer midazolam, which is a very short acting. For procedures, always avoid diazepam. We'll get to clonazepam. It is more of a neuropsychiatric drug or psychiatric tool, but you will see it used in the wards. So it is available in many brand names like Lonazep. These are long-acting benzodiazepine, commonly used for seizure disorders, panic disorders, restless leg syndromes, akathisia, nocturnal myoclonus, generalized anxiety disorder. All these patients, and also can be used for insomnia patients. So dosing is preferably 0.25 to 0.5 milligram at night initially for panic disorders. Then maintenance can be given at 0.5 to 2 milligram per day in divided doses. Can also be used for seizures, but not so commonly used. So role of a general physician in case of clonazepam is usually continue home dose, avoid escalating without neurology or psychiatry input in case of usage of clonazepam. Watch for excessive sedation on top of other CNS depressants. There is more incidence of worsening gait, falls, confusion in elderly on using clonazepam. So never use this as a first line hypnotic or anxiolytic. Don't start clonazepam from the scratch for general insomnia and anxiety on medical ward. In case of elderly and cognitive impairment, it is highly deliriogenic in elderly, so always use with caution. Next, coming to midazolam, it is always used for ICU and procedural patients. It's a very short, sharp procedural sedative. It's mainly used in ICU, endoscopy, or NIV tolerance, and for emergency seizure control. So when to use this in ward? Mostly for procedural sedation such as endoscopy, cardioversion, acute agitation requiring rapid IVIM sedation, breakthrough seizure. Only in these conditions. And for other reasons, try to avoid usage of midazolam. So the procedural sedation with monitoring and research backup we can use for up to 0.5 to 2 milligram IV slowly over 2 to 3 minutes. Titrating to effect may repeat small increments to total of 5 milligram or so, depending upon the age and comorbidities. So always start low, that is up to 0.5 to 2 milligram IV. For NIV tolerance and ICU sedation, can go for as a continuous infusion with after small boluses, then infusion of zero 0.2 to zero point 0.1, zero point 0.02 to zero point 0.1 mg per kg per hour. This drug is mainly for ICU usage and ICU territory. Should not run these without full monitoring and protocol. Because it is very lipophilic, it redistributes fast. It has a short clinical effect after small boluses, but accumulates within infusions, especially in obesity and organ failure patients. So high risk of respiratory arrest if used casually on the wards. So as a general physician, you will more often inherit midazolam models in mainly ICU or endoscopy than start them yourself. So treat it like a mini propofol in terms of respect and monitoring. So Z drugs, these are the newer anxiolytic sedative drug. These are now considered the go-to sleeping pill for short-term insomnia. These are non-benzodiazepine hypnotic acting at GABA A receptor. Pharmacology is similar risk to benzodiazepine. The indication it is used for short-term management of insomnia, where insomnia is severe, disabling, and uh, non-drug measures have failed. It is used mainly in short-term only, up to 2 to 4 weeks. So guidelines advise Zolpidem, Zopiclone as short-term agents, maximum 2 to 4 weeks, and recommend using lowest effective dose with no preference between them. You can use either Zolpidem or Zopiclone. With no choice should be based on cost and patient factors. The general adult dosing, it is available in India as Zolfresh, Zolcalm if combined with melatonin. Standard is a low dose, that is up to 5 to 10 milligram per ml, which is immediately before bed. Ensure at least 7 to 8 hours of available sleep. So elderly and hepatic impairment patient or low body weight, you can use a maximum of 5 milligram HS. So there are a few contraindications, just again the same as benzodiazepine groups, such as OSA, COPD, respiratory failure, elderly and fall risk, concomitant CNS depressant use such as opioids, alcohol, antihistamines, pregabalin. So in these patients, try to avoid Zolpidem. So prior complex sleep behaviors such as sleepwalking, sleep driving, cooking in sleep, all these kinds of complex sleep behavior disorders can be aggravated by the use of Zolpidem. So hence, try to avoid usage in case of complex sleep behavior disorders. The common side effects are again somnolence, then dizziness, ataxia, confusion. There will be rebound insomnia in case of usage of Zolpidem, such as if you stop Zolpidem without tapering, can cause rebound insomnia on the next day. There will be dependence, there can be tolerance if used for long term. In a good use case, it can be, for example, in a 40-year-old male with acute medical illness, pain control, no USA, no organ failure, but severe distressing insomnia for several nights because of hospital stay. In these kinds of patients, a 5 milligram HS for 3 to 5 nights alongside a sleep hygiene is recommended. So, in an elderly patient with the COPD on whom oxygen falls in the past 6 months, and try to avoid. Prioritize non-drug, treat pain, adjust timing of diuretics, do other things than giving Zolpidem. So the patient on morphine plus pregabalin, never give Zolpidem. There is huge risk of respiratory depression. If absolutely needed, only very low dose under close monitoring. So quick comparison between inpatient sedative that we previously discussed. Lorazepam is onset is very fast. That is 20 to 60 minutes. It is an intermediate acting, up to 6 to 12 hours of action. It's best used for acute anxiety, alcohol withdrawal, status epilepticus, symptom insomnia. Avoid in delirium, severe COPD, encephalopathy, substance use disorders. Diazepam, it is a fast acting IV, very long TF. It's long acting. So used for alcohol withdrawal with fixed dosing and fixed tapering. Can also be used for seizures. Elderly patients with liver disease, cirrhosis, childbirth B and C classification, high fall, encephalopathy risk, all these kinds of patients try to avoid diazepam. Clonazepam, as we discussed, is a faster acting 30 to 60 minutes. It's a long TF. Seizures and panic disorders, it is best used for never start in as a new drug in case of insomnia, anxiety, elderly, or delirium. Use only if other drugs are not able to be tolerated. Midazolam, it has a very short onset and fast onset effect in seconds, given as IV, bolus, or in infusion. It acts very shortly because of increased redistribution due to lipophilic effect. Is used mainly for pre-procedural sedation for endoscopy cardioversion and ICU for NIV maintenance and for status epilepticus. Avoid usage in wards unmonitored. So, unstable airway also, patients with unstable airway, avoid use of midazolam. Zolpidem, the Z class of drug, the onset is within 15 to 30 minutes and it is of a short duration up to 6 hours. It is used for short-term insomnia in low risk adults. It is best for inducing the sleep onset. So avoid in complex sleep behavior disorders, uh, substance use disorders, elderly, OSA, COPD, and all these kinds of patients. So how to think as a general physician before you sign any of these orders? First line for insomnia is correct underlying issues such as pain, dyspnea, frequency, steroid timing, caffeine, all these things. So if you must sedate, choose the shortest acting, safest agent. That is preferably lorazepam or a zolpidem. So if for any repeated need beyond a few days, so think yourself that if you need a psychiatry input, or should I be starting an SSRI or antipsychotic? So always document clearly the indication, the dose, the review date, and whether the patient was warned about the side effects. So and of deep prescribing, if for anything more than 2 weeks, try to taper rather than stopping abruptly because benzodiazepines can lead to withdrawal as well as dependence on benzodiazepines. So melatonin, we'll discuss shortly on melatonin. It is an endogenous hormone synthesized in the pineal gland. It is a normally produced hormone in the human body. It is regulated by the suprachiasmatic nucleus. It promotes the sleep initiation and regulates circadian rhythm. So it is pharmacologically extracted and used as a chronobiotic. That is, it resets this circadian clock and also acts as a mild hypnotic. So, what are the indications? It can be used for elderly patients. It has no effect of like respiratory depression. So, it is purely for sleep induction and maintenance and regularization of the circadian rhythm. So, in case of elderly, it is safer than benzodiazepines and Z class of drugs. So, you can always use melatonin. It is available in 3 milligram. It can go up to 5 milligram to 6 milligram per day. It can be used in patients with obstructive sleep apnea, COPD, as it does not depress the respiration. It is used for post ICU sleep disturbance, patients with substance use disorders, jet lag, shift workers, all these patients where the circadian rhythm is being reset, delayed sleep wake phase. In case of delirium prevention, agitation in post op patients, the evidence shows small but consistent benefit in reducing delirium incidence in high risk elderly hospitalization. Can also be used as an adjunct in migraine and cluster headaches. It is off label with modest evidence. So advantages, it is low respiratory depression, safe in COPD or OSA. There is no dependence or withdrawal. It is safer in elderly and delirium prone. It is a chronobiotic, where resets the clock. So dosing is routine insomnia. It is given as 3 milligram HS, 1 to 2 milligram in frail patients. In case of delirium prevention, up to 2 to 3 milligram HS. For circadian reset, it is zero point 0.5 to 1 milligram, 4 to 6 hours before bed. So few contraindications and cautions or limitations. If you give along with warfarin, try to avoid because increased INR variability is reported. In case of immunosuppressed patient, transplant recipients, there is theoretical immunomodulatory effect. So try to avoid melatonin. In case of autoimmune disorders, there is theoretical activation of autoimmune diseases. So try to avoid. In case of pregnancy and lactation, there is insufficient safety data. So try to avoid melatonin. So limitations, it is a very mild sedative effect. It is not a very strong hypnotic. So the patient may not feel the relief from insomnia or may not help to get sleep immediately, such as usage of Zolpidem, Lorazepam. It may not be used as an immediate sedative, but it affects takes 2 to 3 days. The onset of the effect may even be delayed up to 6 to 10 days for full effect in case of circadian disorders. It is ineffective for severe agitation and pre-procedure sedation. There can be few common side effects with the use, such as headache, dizziness, nausea. There will be vivid dreams. There will be mild next day grogginess. All these kinds of things can happen with melatonin. So, when not to use melatonin, when there is a requirement of rapid short sedation, such as in severe case of agitation procedures, it is completely ineffective. When the patient expects immediate hypnotic effect after one dose of chronic insomnia, it is completely ineffective. In untreated depression, anxiety, where insomnia improves with primary treatment, it is completely ineffective. In complex sleep behavior disorder history, it is extremely rare with melatonin, but better to be cautious. In these kinds of patients, avoid melatonin. So, mainly as a clinician, try to consider whether the insomnia is due to pain, usage of steroids, in case of ICU noise, or nocturia in case of diabetes or diabetes insipidus, in case due to delirium. Consider all these causes. Fix the cause first. So then give a sedative. Sedative can be used as a temporary relief, but the cause fixation is to be given the prime importance. So if the patient is on high fall risk or having respiratory disease, melatonin is ideal. Don't give any other benzodiazepines or Z class of drugs. The patient having severe psychophysiological insomnia, melatonin alone may not be sufficient. Consider trazodone or metazapine. So melatonin is the safest, gentlest inpatient sleep agent, ideal for elderly, respiratory disease patients, and delirium-prone patients, but expect only moderate efficacy in case of usage of melatonin. So finally, for the physicians, fix the cause. This is pain, noise, dyspnea. Use a non-drug sleep hygiene. If sedation is needed, use the shortest acting at the lowest dose possible. Stop as soon as possible. If used for more than 2 weeks, taper and then stop. If you learned something about the sedatives that are used commonly in the inpatient settings, we'll continue this series with the usage of antidepressants and antipsychotics. This is Medicine Beyond Harrison signing off. Thank you.